So we started by talking about the plates and screws. It's part of the rehabilitation engineering, and we would like now to start talking about some technologies that we can use to accelerate bone healing, because orthopedics is part of our rehabilitation engineering, and I want you to know this. So I would like to talk about two things: electrical stimulation and ultrasound stimulation to accelerate bone healing and to improve the health of bone. Now, one of them will be good for cartilage, and the other one will be for the bone. Do you know what the bone cells are, the types of bone cells that we have? We have the osteoclast, and then there is another type called chondrocytes. Those chondrocytes are the cells that makes cartilage. Now, cartilage is the soft tissue in the bone, especially on the ends, and it's made of collagen. And collagen is a triple helix structure, and it gives the elasticity of the bone, right? Osteoblast and osteoclast, they balance the hydroxyapatite, the minerals deposition in bone. Now, we're going to be looking into different devices, and they are actually FDA approved to accelerate bone healing, to improve bone healing. So we will look at the electrical stimulation, and those are different ways to do the electrical stimulation. You can do electrical stimulation on the surface of the skin, or you can have things like electrodes implanted in the bone. So those things goes inside the bone, and they do it. So this is invasive, and that's non-invasive. People use also different types of, energy, heat, and light to accelerate bone healing. So I've tried a lot of these. You can say, well, I'm using electrical stimulation like this with these two electrodes, and you say, well, I'm seeing that the bone is getting stronger. But we need to understand what is the thing that this electrical stimulation affected. Did it affect the osteoblast, or the osteoclast, or the chondrocytes? So the history. People tried to do electrical stimulation since the beginning of when we started using electricity. And they were thinking, well, if electricity is affecting nerves, it should be doing the same for all the tissue. And then they will start doing this for bone as well. Now, 1950. So 150 years later, all the ideas or the interventions, they were not useful. But in 1950s, Usoda found that electronegative and positive potential in bone under stress. So what he did is that he was pressing bone, and he discovered that we can create electrical potential. Now, what do we mean by potential? It's a voltage. So what is happening there is that when he was pressing on the bone, what is the thing that creates electricity in our body? It's not electrons, it's ions, right? The positive ions and the negative ions. So we have minerals in the bone, and we have calcium. Calcium is positive, chloride is negative, sodium is positive. So when you have these ions in the body, when he was pushing on them, they were aligned actually to create like a piezoelectric potential, positive and negative on the two sides. And that's actually, so pressing the bone, you will have positive and you have negative, and then charges, and then because of the ions, and then we have biopotentials. And that was during mechanical loading. Still, it was raw. It's the beginning of them, really experimenting with that. So after that, he applied electrical potential to bone. So he said, well, if we have ions and we have biopotential, well, what would happen if I induced potential on the bone? So people start seeing bone formation at negative electrodes. So if you have positive and negative, just like the battery, the negative node will have more bone formation, and the absence of new formation on the positive electrode. Now, this is an observation. We need to know why is this happening, and can we design things that can accelerate that bone healing? And that's actually how we approach things. You look at the observation, and then you study what is going on with the bone. Now, 1960s, people suggested local electrical energy could induce new bone formation and bone growth, and make sure that it could induce, right? So they were not sure, and they need to be able to control the induction of bone. So seeing some bone formation is one thing, but controlling how much bone should be formed, that's another story. In the 1980s, so that's not far away. All of this is still recent. So 1980 studies on the electrical stimulation of healing fractures were published, and the focus mainly on non-union or delayed union. Remember, we talked about this multiple times. If someone is healthy and there is a bone fracture, we don't intervene, right? We let the surgery take place and everything is happy. But if you have non-unions, which means that if someone has a fracture and we placed a plate and for more than 6 months, no healing, that's called non-union. Delayed union, that you're seeing some healing, but it's taking a year actually. So that's called delayed union. Now, diabetes, osteoporosis, smoking, alcohol consumption, it will result in non-union or delayed union, especially when someone does have, they have a fracture. So in the 80s, that's good news. We're seeing people start, publishing. Now here's the thing. The electrical stimulation, we can't just put electrical current or voltage on the body. You can create microshocks and macroshocks. So that's dangerous. So we need to look at what are the types of electrical stimulation that can be used in the body, and they are not going to harm the body. So we have something called PEMF, pulse electromagnetic field, and I tried PEMF when I did my PhD. So we created like a cuff, and you put the hand or the limb inside the cuff, and it is creating electromagnetic field around the bone. Now, this is powered, delivered in bursts. So it's pulsed electromagnetic field. And the reason why we're picking pulse is that a lot of things in our body, it tends to respond really good for pulse type of energies. Now, that's the PEMF, right? Now, the electromagnetic field is made of two things, electrical field and magnetic field, correct? Now, we have something called combined magnetic field, and that's time-varied electrical signal superimposed on a constant magnetic field. Now, the pulse electromagnetic field, both of them, the electrical and magnetic signals are pulsated, right? You pulse, you stop, you pulse, you stop. For the combined magnetic field, you have a constant magnetic field, but you're adding on it a pulse electrical signal. And that is actually, this is 2003, that paper. So this is recent as well. It's not far away in time. So people start using these things and trying to come up with cuffs, chambers, all of different designs to do this. And we tried it with diabetic rats. It did not work well with the diabetic conditions. But this is the paper that you can go and search if you want to learn more about the using of these two technologies. Remember, this is technology for us. We have a medical problem, which is the non-union and delayed union of bone. Now, it doesn't matter what is the cause of the delayed union or non-union, but we do have, let's say, a physician who diagnosed someone with delayed or non-union bone healing fracture, and then we would like to use technology. So our job was, I designed a PEMF system, a pulse electromagnetic field, but it didn't work well actually with the rats. There is a lot of reasons why would that be a problem, but people kept going into this. Now, how do you apply it? We have something called direct current or direct contact with bone. So you have these electrodes and you implant them inside the bone, implantable devices, percutaneous through skin and tissue to bone. So that's invasive. And we have a lot of problems and infection with that. You can do something called capacitive coupling. And that's what I did with the rats. So the capacitive coupling is that you put something outside the body over the skin. And you can also, even if you have a cast, you can put it outside the cast because the electromagnetic field is there. So we have direct current or capacitive coupling devices. Even our cell phone creates an electromagnetic field, right, around it, and receive electromagnetic signal because of the transmission of the signals. So these are the things. Now here's the thing: if it's implantable inside the body, which is implantable direct current, what are the advantages? Constant stimulation to bone directly at non-union or fusion site. So it's very local, right? Which is good. Increase patient compliance. Now, compliance is a problem because people, if you give them a device, they're not going to follow the instruction 100%. Life happens and people forget. And then even if they are using it, they're not going to be consistent at what time during the day. And so the implantable is increasing patient compliance, optimize position of electrodes because the physician is going to place them. The problem with them required an operative surgery, risk of infection and pain at implant site is actually common with these things. Now, if you have capacitive, it's outside the skin, it can be outside the cast. Now, thickness of the material is important if you put it outside the cast. So if the material is thick, the cast is thick, is not going to help us with it. Treatment time goes 3 to 10 hours per day, and that's a big problem. Imagine someone having something with his hand on his hand for 10 hours, or has to be on a chamber in a chamber for 10 hours. That's a problem. The advantage is no need for risk, surgery removal, reduced risk of infection, patient compliance. It's a big problem. It's really hard to have people comply for the electrical stimulation. And then, does it work? So we're saying that, well, okay, people are reporting that we have more bone, but what is going on? What is the thing that is creating the new bone? So people went, after looking at this observation, they go deeper. So they did in vitro studies. So they took the cells, they took the bone cells, and they exposed them to electrical stimulation and see what are they going to be doing or how do they behave. But here's the thing, it's still in vitro, which means that it is not a representation of what's happening inside the body. So people did the publications, so 1, 2, 3 publications. People, when they did electrical stimulation for cells, they found that cells involved in bone formation can be stimulated by electrical and electromagnetic field. So what is the electrical stimulation going to do for these cells? They're stimulated, but what is happening to them? So we were looking at those. We found that osteoprogenitic cells, which means osteoblast cells, or the cells that make osteoblast, the ones that they form the bone cells, from the bone marrow and fracture cells, they increase synthesis of extracellular matrix molecules. Remember, our cells, they don't live in vacuum or in liquids. They need to have this extracellular matrix. They attach to it. And the extracellular matrix of the bone is different in its composition of the proteins from the extracellular matrix of the heart. So each organ, the cells of that organ secrete proteins to build that extracellular matrix. And that's that's an important principle, because stem cells, if you take stem cells from the bone marrow and you put them in the heart, they will become heart cells, myocytes. Put them in bone, they will become bone. Put them in kidney, they will become the kidney cells. The reason why they are differentiating this way is because of the extracellular matrix. So we found that if you have osteoprogenitor cells, which are the cells that are going to become osteoblast, expose them to electrical stimulation, they create extracellular matrix molecules. These molecules are proteins. Now, here's my question to you. Those extracellular matrix molecules, are they bone? No. Our osteoprogenitor cells, which is osteoblast cells, if you expose them to electrical stimulation, they are doing something, but they're not making bone. So it's not helpful for our purpose. Now, osteoblast cell proliferation and activity increase. So the osteoblast start making more osteoblasts, right? They're active, they're proliferating because of electrical stimulation. Now, the bone marrow cells, which is different from the other two, enhance cartilage formation and endochondrial ossification. So we have more soft bone. That's what we call it, soft tissue, because of electrical stimulation. So it's not helping us much with hard tissue. Now, here's the thing. Some cases, you would need actually more extracellular matrix and more bone formation, more cartilage. And that's when you use electrical stimulation. Now, you do in vitro, right? In vitro means in a petri dish. You need to go to the next level, and you want to do this on animal experiments, right? So usually this cascade is, you start with cells, then you go to rodents, mice, and rats, and then you go to canines, dogs, and pigs. and then you do any clinical trial, human clinical trial. So they use rabbit or canine tibia or fibula for non-unions. So you can have a fracture, create a fracture, and then take some piece of the bone, make it very big, critical size defect. So that's not going to have a union. And then they did electrical stimulation on the animal, tibias. They found increase in callus volume. Again, the callus is the cartilage, right? It's not the bone itself. Bigger calluses. We found mechanical strength, but it's because of the big callus, because it's spherical, big callus, but it's not bone inside it. And those are the publications. Now, responses to electrical stimulation are a complex interaction of mind, environment, growth factors, which are proteins, right, and signal transduction. Because you're giving electrical stimulation, you are disrupting the ion passage in and out of the cell, and that's called transduction. Now, people did experiments on human cells. Now, human cells are clinical trials. So if you're doing experiments on human cells, it's just like a clinical trial, like a human being. So human fibroblasts demonstrate an increase in calcium uptake in response to electrical field. Here's the thing. Do we need cells to take calcium or deposit calcium for bone? Deposit. We're seeing that they're taking the calcium out. So cells are taking calcium in and creating more cartilage, but that's not what we want for bone. Many studies suggest an effect or modulation on the specific cell response receptors. Electrical stimulation has been shown to increase the messenger RNA. Messenger RNA goes out so that it's going to be translated using the to protein. If we are saying we are seeing increased messenger RNA, which means that we have higher transcription of the gene regulation. So the cells are making more proteins of these things. So they were making a protein called bone morphogenic protein, PMP2, and 4, two of them. And then we have insulin-like growth factor 2, IGF-2, and we have something called transforming growth factor beta, TGF-beta. These four proteins, those proteins, they can stimulate. So this is the gene now in the gene. So we started with cells. We did animal experiment. Now this is gene. We would like to see exactly what is happening. Those proteins are all related to cartilage formation, not to bone formation. So the electrical stimulation is helping create more cartilage, not more bone. And those are the publications here. I should add my publications here next time. And then people did clinical studies on humans. Now this is not human cells, not animals, not gene regulation. This is humans. Those are the big ones, the big fractures actually in the femur. And people use, what's placebo? No treatment, right? They were just placed in that cuff, but with no electrical stimulation, or active PEMF, pulse electromagnetic field, and they were treated for 3 months. We found greater bone density and trabecular bone bridging in PEMF treatment. So we have more bone formation and more density in that thing. Now, in the tibula, so this is the femur. In another tibula, fresh means an immediate fracture, and they did surgery immediately. So it's not a repeated surgery that they had the surgery and then they had to do it again. So fresh, the first time. When they did it on the high tibia osteotomies, they see advanced healing. 72% of the patients treated with PEMF. Now the problem with this is all good news, but it was not statistically significant. Big difference between the two, and we need to understand what is happening with the cells. Those are the publications for these two. 4 controlled study identified to compared to bone grafting. Grafting means we have a big chunk of bone went out and they filled it with bone cement. That's grafting. And 2 compared to placebo. So here's the thing. Grafting is the gold standard, right? So if someone go to surgery and there's a big chunk of bone removed, let's say for cancer, they removed a piece of the bone. The gold standard is to fill that with bone cement and put plates. That's called grafting. So they did a grafting, but then they did the same surgery and compared it with PEMF, pulse electromagnetic field. And then they did the same, PEMF and placebo. PEMF and compared with the placebo. Placebo means nothing. They didn't do anything for that thing. So to the bone graft, the PEMF demonstrated equivalence in the two techniques. So bone grafting and PEMF resulted in something similar. There was no advantage on having the electrical stimulation. So here's where it becomes confusing. You need to have consistency in the results. If you're seeing that something is not working as you expect it to work, then there's something going on other than what we're thinking. So it was all cartilage, not bone. Compared to the placebo, delayed union risk, displacement, angulation, and soft tissue injuries, 12 weeks of treatment of PEMF. We have 45 treated with PEMF healed, so half of them healed, 12% with the placebo healed. So if you didn't do anything, 12% will heal. But if you did the PEMF, you have 45%, which is a good thing to look at. It's good, but there's no consistency in the publications. Not all of them will report that thing. So what happened is that observational studies, large multi-center studies. When you say multi-center, it means a lot of hospitals do that. Electrical stimulation techniques, 84 patients. We have physicians diagnosed 47 with delayed, 37 non-unions, 72 out of the 84 healed. Yeah, and so 72 out of 84, including ones who didn't get the PEMF. And that's how it starts being confusing now. Delayed union or non-unions of the tibia, DFSs, 87 union rates, and then 64 and 77 rate at 8.5. So each one of them start giving you different results based on different times. So this is from 3 to 6 months. You are getting 64, but 5.8, 77, even though it's within the range. So that we start getting different results. That's not consistent, which means that this is not probably the best thing to go for. And those are some types of electrical stimulation products that they are available in the market. Actually, people can use them here. So Biomed is a company that makes these technological devices, and you can apply for them actually for jobs. The Biomed company, it's a big one. It's a big company. And let me stop here with the electrical stimulation, and we'll do the ultrasound next time when we continue with that. Electrical stimulation is good for cartilage, not for the bone healing. And we will learn that ultrasound is way much better for bone.